to respect everybody's time. Going to officially get started. Well, hello, everyone. I would like to welcome you all to our virtual speaker series for 2025. Today's webinar is titled Substance Use as a Result of Trauma. It is being provided by the PA Care Partnership, which is a statewide system of care grant in association with the Office of Mental Health and Substance Abuse Services, better known as OMSAS. Our presenters today are from VIP. We have Chelsea Falatico, who is our Community Outreach Manager for the Victims Intervention Program. Chelsea has been in victim services for nearly 10 years, starting as a case manager at a domestic violence shelter in New Jersey. She quickly realized that this was more than just work for her. It became her passion. Now, as the Community Outreach Manager of VIP, she takes pride in educating the community about the complex issues survivors of crime and abuse must face every day. And we also have Erica Thaxton, who's the medical advocate. With a long history of working in both victim services and healthcare, Erica has been able to see firsthand what patients and medical providers experience when dealing with violent interpersonal crime. She began her time with VIP in 2016 as a volunteer, taking crisis calls after hours. Erica now serves as the medical advocate. She is dedicated to bridging the gap between victim services and healthcare providers throughout all of Wayne and Pike counties by adopting a trauma-informed culture. With that, I will turn it over to our presenters.
All right, thanks, Jamal. All right, Chelsea, I'm going to go ahead and start to share my screen. So just give me a second and make sure I do it right. Okay, you're good. You can see just the screen there. And okay, and you don't see me anymore either, correct?
I mean, I see you. Are you trying
Okay.
to, are you trying to
No,
be
I'm just
visible?
trying to make sure that I did this right. All right, so welcome everybody. Thank you so much for joining us. We are going to be talking today, going a little bit behind the behavior of using substances and looking at the hidden role that trauma plays in that. Trying to figure out the best ways to recognize and respond to trauma-driven substance use, but also give you those real-world practical tools to help you moving forward. We are talking about difficult topics. Every time that Chelsea and I end up coming on here, it's never about happy-go-lucky things. So please know we want you all to take care of yourselves. We want you to do whatever you have to do, whether it be step away, take a break. It's being recorded, so you can always re-listen to it later. Or on the other hand, if you missed something or want to rehear a part, you'll be getting the link for that as well. Please use the Q&A feature for any questions, and otherwise you can use the chat for everything else. But the chat moves so quickly, we can't keep up and try to see the questions that come in. Really quick little bit, we work with VIP or Victims Intervention Program. We're a victim service agency out of Wayne and Pike counties. We serve people whose lives have been affected by trauma, crime. We have both 24-hour services as well as regular services. 24-hour stuff, we have the hotline, we have an emergency shelter for people affected by domestic violence. We can also do medical and legal accompaniments. Otherwise, we do counseling, a lot of different advocacy work, prevention and educational outreach, as well as looking at it in a whole picture type of thing. We do a lot of independent living type stuff. So it's not just about managing your safety and things going on right now, but how can we keep you from hopefully ending up in this situation again, or what can we do to help you moving forward to be as most successful as possible? Today's goal is not to diagnose anything. It's just to understand, develop that awareness, empathy, and practical tools. We're going to be recognizing how trauma manifests in substance use, or hopefully we're going to be doing these things if we do our job right. Reframing substance use as a coping response or skill to trauma, apply trauma-informed engagement strategies, and strengthen that cross-sector collaboration that we all know and love. So why does this topic matter? Well, 59% of young people with PTSD will develop substance use problems in the future. 1 in 5 veterans with PTSD also have a co-occurring substance use disorder. In 2021, there was a group of postdoctoral graduate students from the University of Washington who were looking into this topic, and they were surprised at there really hadn't been many studies done to show how many patients that come in to the emergency room, say with an injury, how many of them that also present with PTSD type symptoms have a substance use disorder underlying as well. And what they found was through this multi-site investigation, between 62 and 79% of injured survivors who come into the hospital with PTSD symptoms have 1 or more alcohol or drug use comorbidity. Those are huge numbers when you think about the patient population at your level 1 trauma hospitals. In 2022, 18% of all Pennsylvania adults were regular binge drinkers. Pennsylvania is also ranked 14th highest in the United States for overdose drug fatalities. And an average of 14 Pennsylvanians will die every day from overdose. What is trauma? To be simple, trauma can be defined as a deeply distressing or disturbing experience that overwhelms an individual or a community's ability to cope. This can result in lasting adverse effects on mental, emotional, physical, social, and spiritual well-being. When you go through some form of trauma, there is truly not an area of your life that it is not touching in one way or another. Trauma can be personal, such as abuse, assault, incidents or accidents, things of that nature. Collective, where it's throughout the community, whereas if there's war going on, a natural disaster, chronic exposure to unsafe or community violence. There's also systemic or structural, and that's when we look at things like discrimination, poverty, forced displacement, or inequitable healthcare. A lot of your social determinants of health can fall under systemic or structural. We also have acute, chronic, or complex. Acute would be one isolated incident. Granted, I don't think any of us ever go through life with a single incident of trauma, but they are spread out. They are not related in any way. Chronic is when it's repeated or prolonged exposure. Complex is constant. It is coming from multiple different areas inside the home, outside of the home, everywhere. Everywhere you look and work in a daily space has traumatic events. The issue is that trauma is never just about the event itself. What's traumatic for me may not be for you. You know, so we all have people in our lives where we're like, oh my gosh, they are just dramatic and they blow this whole thing up, right? And granted, yes, that is true. But on the other hand of that, from a third party, you can't judge how someone else is affected. Trauma is completely subjective to the experience of the person living it and the impact that it has on their daily functioning. You can't talk about trauma without talking about ACEs, or the adverse childhood events. This is called an ACEs pyramid. Trauma affects all areas of life, including brain development, physical and mental health, relationships, life opportunities, especially when it happens to us earlier in life. The ACEs pyramid was originally developed by the CDC and Kaiser Permanente, and it illustrates how adversity can affect health and well-being across someone's lifespan. So from the bottom up are different levels. You have things like generational or historical trauma that can be passed down through families and communities, social conditions, because where we live matters. Then your adverse childhood experiences. In the resources that you receive, you will actually, I'm sending a actual example of the ACEs questionnaire if you aren't aware of those already. But those are basically, they look at things that children have to face within 3 categories: possible abuse, neglect, family history, instability, things like that. Then we have disrupted brain development. Growing up in constant stress, we know affects how our brain not only develops, but works on a daily basis. Social, emotional, and cognitive impairment. Kids can struggle at school or with relationships, self-esteem issues. Socially, health risk behaviors. A lot of times people may turn to substances or unhealthy eating or have other risky type choices in life based on the things they've went through when they were younger. Disease, disability, and social problems. Over time, unaddressed trauma and stress can lead to serious health issues and life challenges. Lastly, early death. Trauma effects can add up and eventually shorten lifespan unless that cycle is interrupted somewhere. Trauma and substance use are deeply connected. When people experience trauma, it can change how their brains and bodies react to stress, pain, relationships, even everyday decision making. Substance use often becomes a way to cope, escape, or feel in control when other coping skills aren't available to us, or when it's the only thing that we can control. A trauma response is how a person's body and brain react to the threat or overwhelming experience. These responses are purely survival mechanisms. They are not choices. Your common trauma responses include fight, flight, freeze, or the newer one, fawn. Fight, obviously, being anger, aggression, controlling type behaviors. Flight can be anything from actually withdrawing or avoiding a problem to having anxiety or feeling restless. Freeze, that numbness, shutting down, like out of body type experience. And fawn is trying to avoid the problem altogether by doing whatever you have to do to make it go away. Overly pleasing or people pleaser type. It's important to understand that all of these are normal and yet automatic ways that our bodies and brain tries to keep us safe. How we respond to one event has no bearing on how we respond to another event. You can face the same event multiple times in life and respond a different way every time. There are people who typically will respond in one way, but please know that is not guaranteed. There is no, oh, I'm a fighter, or I'm a freezer, I just shut down. There's honestly no way for you to know what you'll do until you're in that situation. When trauma is left unresolved, people will turn to substances sometimes to numb pain, whether it be emotional or physical, feel calm in an anxious or hyper alert state, maybe to escape flashbacks or nightmares, memories. They may use substances because they need help falling asleep, staying asleep, even to socialize or eat, to have that appetite. Sometimes they use substances just to feel something because they're so shut down and turned off from the world. It's the only thing that they can feel. In these instances, substance use is not bad behavior. It's not a character flaw, and it's definitely not a choice. It's an adaptive survival strategy that has been made in response to those overwhelming feelings and experiences. All right, listen, this is super boring. If you're not a scientist, I'm not a scientist. right? So we are going to try to package this up in a cute little bow and let it go. So the brain on trauma, right? Trauma causes significant changes in brain structure and function on multi-levels. Specifically, your amygdala, your hippocampus, and prefrontal cortex are often severely affected or affected the most. This impacts everyday functions like processing emotions, how we perceive memories, and how we react to threats now and in the future. Your brain stem is the most inner part of your brain. It is tucked away, it is nice and protected because it is responsible for all of your survival instincts and all of the functions you do every day without even thinking about. During a traumatic experience, the brainstem becomes activated, therefore shutting down everything else and just leaving you in survival mode. During this time, your heart rate will increase, your number of breaths you take will increase, although you may feel like you're running out of oxygen because your breaths become more shallow. Also, throughout this time, your stress hormones start to get secreted, right? So you have multiple things going on. Trauma will keep this part on high alert even after the danger has already passed. Your amygdala, right, which is, let's think, the middle level. Your amygdala is commonly referred to as your brain's alarm system. It's responsible for processing emotions and triggering one of those trauma responses. In some cases, the amygdala can become overly sensitive, constantly scanning for different threats and dangers, and making yourself believe that there's something happening, even when you're in the most safe of situations. This leaves you to consistently question your own level of safety all the time. Then we have the memory center, or the hippocampus part of the brain. Trauma can lead to literally a decrease in volume of this part, making it harder to consolidate new memories and recall past events. This is why when you have somebody that you're talking to, say after they've been through a trauma, they may not be able to remember, even though it just happened. It can result in fragmented memories, flashbacks, difficulties distinguishing between past and present. It'll also keep both the mind and body stimulated in that reactive survival mode because neither part understands the threat has already passed. You haven't processed it from a current event to a past event or memory. Lastly, your prefrontal cortex, right? This is the part that is responsible for all higher level cognitive functions. This here separates us from most animals, right? With this, we can make decisions, we can regulate our emotions, and it helps with our impulse control. When trauma happens, we may see changes in the prefrontal cortex manifesting as mood changes, irritability, difficulty focusing, maybe even problems with speaking. In the middle of trauma, a person may not be able to think through the situation clearly and make decisions such as yelling or calling for help. It's not a matter of choice because their brain is in survival mode and it bypasses all of this prefrontal cortex. Remember, the brainstem takes over, this all shuts down. If all of that isn't enough, trauma is also responsible for even more changes in the brain, right? So just as we have those hormones that are the stress hormones that are triggered in traumatic situations, there's also a part of our brain that is responsible for transmitting those happy, feel-good hormones like serotonin, norepinephrine, right? Without those, it leads to increased anxiety. It can also change normal pathways and connectivity. If you think about the brain, let's say as a figure 8, right? And all these neurons connect it. So the signal starts here and it goes around and around and around. And then all of a sudden, a traumatic event comes and now it's got to come over here and it goes around. This is now the normal pathway, right? It's not a straight figure 8 anymore. It has since shifted. Can this be changed in the future to be more healthy? Absolutely. But it takes time and it takes a lot of work. These changes alone are what can contribute to a lot of different mental health illnesses. Untreated and unresolved leads to PTSD, but it also makes us more susceptible to using substances and to developing that substance use disorder.
Oh, this is me. This is where I come in. Okay. So, trauma, as Erica just said, trauma is really a brain body experience. So, the brain remembers trauma in sensations, reactions, not just thoughts, right? It happens to our whole body. And I'm probably preaching to the choir, right? We've all had some sort of trauma happen, and whether it's an emotional trauma or a physical trauma, we feel it both ways. You never just break your leg, right? That's a traumatic injury to your body, but there's also this entire emotional trauma that you have to go through, that you have to work through with this broken leg. So even if a person knows that they are safe, they're in their, I'm in my office right now, locked doors, I am in a safe place, I am in no physical danger. But if I had just experienced a trauma, my brain doesn't always catch up to the physical. My brain might still think that I'm in some kind of danger. And you can't just turn that stuff off. It doesn't, there's no switch to flip, right? Or flip to switch, switch to flip. Got it right the first time. So why does trauma increase our vulnerability to substance use? People who have experienced trauma might use substances as a way to cope, self-medicate for emotional pain, anxiety, or any other trauma symptoms. Trauma also leads to changes in our brain regions associated with stress, rewards, and decision making, which potentially makes it more difficult to regulate our emotions and then resist using substances. There's a disruption in our reward system of the brain. So it makes it harder to experience pleasure from natural sources and then increases the likelihood of seeking artificial rewards like drugs or alcohol. The initial relief from using substances can also create a cycle of dependency. So as the brain becomes wired to associate substance use, I should say, with emotional regulation, making it harder for us to do that stuff without substances. That's how addiction works. And it also, trauma also has an effect on the prefrontal cortex, which is responsible for all of the decision making and impulse control that we have, which again makes it way more difficult for somebody who has experienced trauma to resist substance use. And trauma related mental health conditions like PTSD can coexist with substance use disorders, which then creates a complex situation that we call dual diagnosis or a co occurring disorder. So when someone has experienced trauma, especially ongoing or early life trauma, they might live with hyperarousal, intrusive memories or flashbacks, emotional numbness. They might have difficulty sleeping, trusting. They may never feel safe again. And then substances like alcohol, opioids, stimulants, they come in and they quiet the nervous system. They numb those overwhelming emotions. They help with sleep and social functioning, and they just provide a sense of control and escape. So people often use substances to feel normal, not necessarily to feel high when they've experienced trauma. Next slide. Thanks, Erica. So how do we recognize when substance use is linked with trauma? Erica gave a whole bunch of statistics earlier on talking about that link and how much these two really do overlap, and how people with a higher ACE score or higher people who have experienced more adverse childhood experiences, they are 5 to 10 times more likely to misuse substances as adults. So many people who are living in recovery also have untreated or unrecognized trauma. So some of these feel very straightforward, right? They exhibit signs of trauma, anxiety, hypervigilance. They are very withdrawn or have flashbacks, or the substance use began after trauma or a traumatic event. If you can tell that they're using substances as a way of self-medicating, they might have difficulty discussing the substance use without having a really over the top emotional response because they're not talking about the substance use. They're really talking about the trauma, and trauma is hard to talk about. And if they, like most of us, right, have a history of ACEs or violence or loss or systematic harm in our past. And often it's just important for us to remember that substance use is often not the problem, but it's the response to the problem. Thank you. Some of the gosh, man, we could spend an entire session talking about barriers that people face when they try to get help. There's a lot of them. There's a lot of them. They're on the screen. I don't want to read off the screen to you, but I definitely want to point out a few of the ones in here that I think are a little more complex and layered, like family factors, right? We're not just talking about leaving our family behind if we are seeking help or support for substance use. Because remember, if you're seeking support for this, oftentimes that means going to a rehab facility for 4 to 6 weeks. So that means that you're leaving your family, your life for 4 to 6 weeks, for up to a month. If you're the sole caregiver for your children, what do you do? What do you do for those 4 weeks? If you are in an abusive relationship, do you leave your children with your abusive partner for 4 weeks to go get help? Would your abusive partner even allow you to go get help? That could be a huge factor. If you're a caregiver for an elderly parent or a sick parent, who's going to take care of them when you're gone? These are all like just overlaying layers of thoughts that person with substance use disorders will have to think about. And you're not always in the right mind to think about those things at the time. So it's definitely a huge barrier. Um, Also, the availability of treatment. When somebody wants help, they can't wait 2 weeks or 2 days or even 2 hours for a bed to open up in a treatment facility. When they say they need the help, they need it right then and there. If we make them wait, chances are we're going to lose them. They might walk out of our office and we don't see them again because we don't know where they went. They might have gone back to using, they might have found help somewhere else. But the chances are, if we can't get them immediate help, we've kind of lost our shot with them. So we want to try to break those barriers down however we can. And sadly, most of us aren't in control of what beds are open, what facilities have space in the moment. And there's so many other things to think about in our daily lives too. Some people who experience addiction are functioning. They have jobs, they have lives. Can you afford to take the time off of work to go get help? Would your boss even allow it? And that means that you have to admit to your employer that you are struggling to begin with. And for some employers, the second you mention addiction, you're fired. Bye. That's it. The end. Let alone finding an employer who will say, okay, I'll allow you the 4 to 6 weeks to go get help for that and make sure that you have a job when you come back. That's not how reality works most of the time. So my question for you in the group, how do systems unintentionally create barriers for the people that are seeking treatment? And while you think about that, think about your own organizational policies too. Does your organization have any barriers that might not have been thought of as barriers, but now that you're thinking about it, they might be a barrier? Insurances. Insurance is huge too, because while they might cover some treatment, chances are they're not going to cover the full extent of what you really need. Because I'm sorry, but 4 weeks is not enough. 4 weeks is not enough time for somebody to fully leap into recovery. And also, your insurance might not cover the places that are close to you. So you might be traveling hours out of state somewhere else to get to a facility. Childcare and dependence, absolutely. Staff attitudes. Woo! Yes. And we're
Prior
going to talk about that.
experiences. Yes, prior experiences are huge, not only personal, but the circle around you, you know, like, oh, I went there before and it was da da da. Like, I'm not going to go somewhere that isn't referred by my best friend.
Mm-hmm. I saw stigma too. Social norms. Yep. Yeah. Delayed response. We just said that, right?
The one that just
Is
says, my son wanted rehab, but he stopped using heroin already, or soon I have to scroll back up to it. And without using, you know, like actively, they would not accept him. That's another huge one. It's
Mm.
you're using now and need help now, not because you were or you may restart.
Ageism. I've seen ageism a few times in here, right? And Erica had did we I don't know that we did this as a PA care webinar, but Erica has a really great training that she put together about intimate partner violence in later life. And at the beginning, she talks about how there is an entire population that we don't talk about, we don't study, we have no, like, very little statistics on, and it's our elderly population. It's almost like we stop caring once you hit 60. So I'd love to see the stats on substance use in that population, because I bet it is wild, but nobody recognizes it. So nobody suspects it. Nobody thinks you need help. You've been in this life forever. You should have it all together, right? That's one I never even thought about. That's a good example.
Even just the hours, right? You have your daytime, but if you work second shift, but you need outpatient therapy due to other reasons, most of that, or IOP during the day or evening or whatever, it's hard. It's hard all around. And I don't know how people do it. It's so hard to get help when you need it.
Yep. You can move on to the next one if you want. Thank you. All right, so hold on. Trauma-informed, survivor-centered, survivor-centered practice and approaches. I feel like trauma-informed is kind of like a hype word right now, or hype phrase. Everybody has probably heard of this, but what does it actually mean to be trauma-informed when we're talking about this population? Really, it's just care that recognizes that trauma is common and can shape our behaviors, our emotions, and our health. That substance use might be the only way to manage trauma and not necessarily a bad behavior. And that healing begins with safety, trust, and empowerment, and it shouldn't be punished. What you might not have heard a lot of is survivor centered. And a lot of times these things go hand in hand. So for Erica and I working in a domestic violence center, our work is always survivor centered, which then means that it's usually trauma informed. Almost, we are a very trauma informed agency. But when we say survivor centered, that kind of care just means that the survivor's voice, choice, and goals lead the way always. We, as the care provider, are just kind of like a passenger on a road trip. We always use this bus analogy where the survivor is driving the bus and we're just here with a roadmap saying, there's an exit in 2 miles if you want to take it, and it's going to lead to this treatment center. But if you just want to drive on by, I'll let you know when the next one comes up. That's our role. And that's kind of what survivor centered means, is that they are in control of their own life. So how do we put those things into practice? Erica did a great job at highlighting a few approaches that are really key. And again, I think coming from a domestic violence and rape crisis center, if we're not talking about safety as the first thing, the first priority, then we're doing our work all wrong. So we will always do our best to make sure that people are safe in our agency or under our care. And that doesn't just mean physical safety. Yes, physical safety is huge, but we also want to make sure that people feel safe emotionally and culturally in our space. We also want to create very trusting relationships. We want to be transparent with people. We don't want to lie about what we can and can't do. Because if we make promises that we can't keep, why would they keep coming to us? Why would they keep trusting us to support them? And we want to be able to validate their experiences without punishing them, or pushing, I'm sorry, not punishing, pushing them to disclose. So we know most people who have suffered addiction also have some kind of trauma in their past. We're not investigators. We don't have to know what that trauma is to support them. Especially when we're talking about victims of domestic violence, I think choice and making sure that we are offering choice and control where it's possible in our work is imperative, because that's a population where choice has been taken from them every step of the way. And us being able to give them even the slightest sense of control back is not only imperative to their healing, but also makes it a little more sustainable for them, because they feel like they had a part in their own recovery. They weren't just told what to do, when to do it, or where to go. They had options and they felt like they were part of their own recovery journey, which is a huge step. So instead of saying, you need to do this, or I think you should go here, and shoulding all over people, asking them, what do you think would be helpful? Here's 4 options. Which one feels the best for you? And just allowing them to be in control of their own situation for once. Um, sorry, sometimes I get really distracted by the chat when it pops up and I can't stop my brain from reading what people are writing. Collaboration. So working across systems to make sure that people are getting all the care they can, like coordinating with healthcare, housing, harm reduction, not just the criminal justice system, but making sure that we know all the people in the circle, all the people in one client, patient, consumer, whatever you might call your people, whoever is in their network, we want to know them and we want to make sure that we are collaborating on a level that is treating the person as a whole. And watching our language and survivor-led engagement. So empowering the survivor, like I said, to take control of their own life, reminding them that they are the experts in their life, they're the experts in their situation. While we might have some base knowledge that could help them, we want them to take control. We want them to make these decisions, because if we keep making decisions for them or telling them what to do, then we don't encourage them to learn how to make healthy decisions on their own. And that's the key. We can't just do it for you, because we can't do it for you for the rest of your life. So now is the time to learn how to do things on your own, how to do them well, and how to do them in a healthy way so that you can take that knowledge and take it into the rest of your life with you. So making sure that we are just empowering them to feel good in their skin, asking them what does this help you manage, instead of why are you doing this? Just watching the language that we use when we're talking to survivors to make sure that they understand they're in control and they are capable. They're capable human beings. You can go to the next slide. There we go. Thanks. I sort of touched on language a few seconds ago, but language is a door, and the language that you use can either open the door or shut the door. The words you use can either build trust or it can build barriers. So choose your words wisely. Stigmatizing language just reinforces harmful beliefs about people who use substances, and it labels them as broken or addicts or unfit, instead of recognizing their experiences and their resilience. So we want to try to use people first language, people who use substances instead of drug users, right? Avoiding labels that define or blame a person, using really neutral words and phrases like substance use instead of like substance abuse, because then it labels them as an abuser, which is a bad person, which some of these people just might have made a bad choice or felt like they had no other choice. Using strength-based framing and curiosity over assumptions. So we don't know everything. Like we said, they are the expert in their life. We don't know everything. So instead of assuming that we do, asking, can you tell me more about what's working for you right now? Instead of us just assuming that we know what's going to work for this person. Some examples of, at least one example of language in practice is what we would hear a lot is like, she's non-compliant and refuses to get clean. She's just manipulating the system. And a different way to phrase that, if we're using people first language, is she's been through a lot of repeated trauma and she uses substances to cope. And she's not ready to stop right now, but she does reach out for help when she feels safe. So our job is just to meet her where she is. The end. You're saying the exact same thing, but you're not putting blame or judgment on the person who's seeking help. So reframing is really important because it allows us to see the person behind the behavior and use behaviors as communication. So what Erica wrote here I really like is that a person isn't a problem to fix, right? The people that are coming to us for help are not the problem. They're a survivor who's doing the very best they can with the tools that they've had or the tools that they've been given. And our job is to make sure that we provide them with safer alternative tools to use so that they can survive in a much healthier way. So we want to validate their survival functions. We want to shift from compliance to compassion. So instead of asking like, well, why haven't you stopped? What do you need to stop? What do you need to feel safe enough to get help or to look at other options? I don't know, maybe it's just the field that we work in, but the why haven't you questions, they really get to me because we have a whole presentation and training that talks about how people ask domestic violence victims, well, why haven't you just left? And if it was that easy, well, we wouldn't have a problem, an epidemic of domestic abuse, right? If just stopping was that easy, well, we wouldn't have a substance use epidemic on our hands, right? It's not that easy. These are really complex issues with just layers of complexities that we need to step in and look at the whole instead of just one little part of it. And meeting people where they are, offering support to someone, even if they're still using, because stopping is hard. You can't just stop, and sometimes you can't stop without the right kind of help. And our goal is to help you guys be the right kind of help. And healing's not linear, it goes up and down. We know that people might stop for a few months and then they relapse, and then they stop for a few years and then they relapse. And one of those times, it's going to be the last time. It's going to be forever. They're going to get there. We just need to help them get there. And empowering survivors to make decisions at their pace with support, not pressure. So again, going back to that analogy of the bus driver, you're in control of the bus. Whenever you want to make a stop, you let us know and we'll be here to help you. Here's some knowledge I have about the stop up ahead. Should you take it? Great. If not, let's move on. You can go to the next one. Sorry, I have to like keep moving the pictures of people because it's always in the way of the text. Okay, cross-system collaboration, right? So when someone is dealing with trauma and substance abuse, there's not one single provider that can meet every single need that the person has. Trauma and addiction affect every single part of a person's life, so our responses have to be just as interconnected. Working in silos can lead survivors to fall through the cracks. We forget about them, they get missed somewhere along the line. And that means missed opportunities for healing, increased feelings of frustration, and burnout among us as providers. So, and survivors just being bounced around from one place to another without ever actually getting the right kind of care that they need. And the system will always blame the survivor for it. So you missed your appointments, you missed your check-ins. That's on you. But nobody asks, what was your plan to get here? Was there no public transportation where you live? Did you not have a caseworker who could provide travel? Did they not plan ahead? There is no system in place to help you get to those appointments. So how do they expect you to just get there? They just blame you. The system just blames you. So collaboration between service providers really promotes whole person care, more effective, compassionate responses from us as system advocates, a greater trust between the survivor and the systems as a whole, and then sustainable outcomes, not just crisis management. We're not always going to be seeing them in a crisis because they're getting the care they need, and we're seeing progress every time. So, what does it look like to have cross system collaboration? Partnerships, right? A shelter staff working with a medication assisted treatment provider, a mental health counselor with a peer support specialist, survivor services like Erica and I, domestic violence or rape crisis center, working with recovery housing, who's also working with a primary care physician. All of these people, all of these puzzle pieces coming together to form a whole picture of how to best treat the person that we're working with. Shared language and goals, using that trauma-informed, non-judgmental language across all systems, so creating our own language altogether, and changing the way we talk about our clients, but also the way we talk to each other, I think is really important too. And coming up with this agreement that there is no wrong door. No door is the wrong door. So if somebody were to walk into my office right now who is also struggling with substance use, I know exactly who to call in my county. And I'm going to call her and say, Shannon, I have somebody over here who I think could really use your services, or somebody who's looking for help right now. And Shannon's going to walk her butt right over to our door and say, let's go. How do we do this? What's the best way to help this person? And that is the kind of collaboration we need, where everybody knows everybody and can help get somebody to the right person. Because I don't pretend to be an expert in drug and alcohol use. I'm not. I am an expert in domestic violence and rape crisis. So when somebody in drug and alcohol has somebody who is experiencing domestic violence at home, guess who they call? Me, the expert, because we know each other and we've built these really great relationships between systems that we feel comfortable reaching out to each other to treat the person as a whole, not just treating one little part of their life. And flexibility. We have to be flexible across all systems. We have to be able to respect that people move between stages of recovery and safety and understand each other's role in that person's healing process. Meaning, like, no turf wars. I'm not, like I just said, I'm not an expert in this field over here, but I know who is, and that's your realm. So I'm just going to be supportive while you take the reins. And when it comes back to the safety part in their relationship, then I'll take the reins again, and you can be on the backside just watching from afar. Being able to collaborate with each other is so imperative. And it goes back to the idea of creating a really sustainable change for the person that we're working with instead of just creating more crises. You know what I mean? We don't want them to be in crisis all the time. We want them to get to a point where they can handle themselves and their lives on their own, and they don't really need us. And that comes from being able to work with everybody.
Real quick, there's a really good question here about speaking on how to navigate implementing a survivor-centered approach to the treatment of substance use disorder in the more authoritative context, such as child welfare, when there are mandates for recovery and consequences for lack of progress. That is such a good question, because all of us that work within these fields know, yeah, all of this is great, right? But this is what's been ordered, and this is what has to happen. And if not, there is punishment, or there is an answer there. You know, we as caseworkers or advocates, we can only do so much, right? In those instances, the changes really need to occur from the top down, right? We need to advocate for our clients, but especially in the overall, in the judicial sense, in the legislative sense, you know, when we are making those treatment plans, because the ones that we are at least a part of, really taking into consideration, okay, what is truly feasible and what is not. Is this reality, right? If you know that by putting this goal here, it is not going to be reached, then we are ultimately setting that person up for failure. In a lot of those senses, there's only so much that we can do, but ensuring that we're doing our part is the best way to move forward. And that's how change happens. It happens from one person starting to speak out or starting to change that narrative or push that envelope to ultimately bring everybody else in together. There's not a quick answer, but I just thought that was a really good question, because I'm sure with the variety of participants, a lot of you are in those mandated type of work, or I can't think of the word, community, whatever. And it is hard. And it's hard knowing, you know, this is your job, but on the other side, there is that human aspect to it. But that in those cases, that change needs to happen from the top down. And the best that you can do is just continuing to try to advocate, reach out where you can, talk to one another. If you know that this is not feasible and it's a treatment goal set by X, Y, or Z, don't just send the client out the door. Actually pick up the phone and try to advocate and try to avoid that problem before it becomes a problem.
I also think we can start making those little changes, or at least like laying the groundwork for those changes, by changing the way we speak about our clients and the language that we use. If we're talking about them as non-compliant, 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 and I'm just using that because I know that sometimes those are the words that you have to write down in your case files, however you create files. But the way we talk shapes the attitudes we have about populations. And I saw a few people actually, when we talked about what barriers your organization or the system in general creates unintentionally, a few people said the attitudes of staff, and absolutely. So if we start changing our language and then we start shifting our mindset and our attitudes around this population, it makes everybody and as a whole just, I don't know, maybe more excited to change it. Maybe we start seeing them as people instead of as numbers or um as criminals. We remember that they're human, and it all just starts with the way we speak to clients and the way we speak about clients when we're talking to other staff members or um other agencies or systems. Um okay.
I just got to get back to that screen. Sorry, I was in the middle of
No,
typing.
it's okay.
There you go.
Okay. So just some other additional things that we should keep in mind, right, when we're talking about best practices is, well, we just kind of said this, right? Be flexible, but be realistic. um, Stay engaged even when the progress looks like it's not happening at all. Because like we said, healing's not linear. We might have huge jumps of success and then like backpedal a little bit. And that's okay. That's part of the journey. Every time you backpedal, you learn something. Offering drop-in or low barrier support options when that's possible, and just being really self-aware, aware of your own triggers, your own emotional responses, and just knowing that that can affect the way you present yourself to somebody. That can affect the way you work with an individual, depending on how you wake up in the morning. We're all guilty of it, and we're all here, right? Because most of us are probably in some kind of helping profession, which is hard. That's a really hard job to have right now, is being a helper in general. So making sure that we're taking care of ourselves is just really, really important. Um, and that goes into the next part, is reflect and supervise. If you are somebody who gets supervision with a higher up in your organization, utilize it. Take advantage of your supervisions, because that is your opportunity to process and debrief on everything you've heard, especially if you're working with somebody who has just disclosed trauma to you. Secondhand trauma is so real. You got to take care of it, because that's the number one thing that's going to cause burnout in this field, is constantly taking in other people's trauma, but never having a place to dump it. That's what supervision's for. Dump it on your supervisor and then they'll dump it on theirs. It's a cycle, but get it out of your body. Don't let it live there, because it's just going to hold you down, and it's going to affect the way that you work with the next person. And just prioritizing your wellness, because we in this profession, we preach a lot about self-care, right? But you need to understand that self-care is not just a face mask or a glass of wine. Self-care is much, much deeper, and do your best to figure out what self-care actually is to you and how you can fit it into your life, and make sure that you are taking care of yourself. And if you are a leader, making sure that your team knows how to take care of themselves, so that we don't end up with burnt out staff who use really degrading language and then pass that stress and trauma on to the people that they're supposed to be helping. I cannot stress self-care enough to my fellow helpers out here. We've got to do it, guys. We've got to do it. A supported staff equals supported clients. Next slide. Okay. So where can you actually find help? We have all of these on a list. So that's going to be coming out to you as a resource list in the next day or two. So keep your eyes open. All of these are on there for you to call, for you to give out to people who might need some help, to look up and get some information. I think the one that I definitely want to highlight, though, is the Commonwealth's website, pa.gov. It's a great resource. You can really find contact for anything that you're looking for, or any information that you're looking for. But they have contact info for all of the county drug and alcohol offices and treatment centers. And then you can also look at reviews for treatment centers, reviews, licensings, and official state inspections. You can see all of that on the Commonwealth's website. So if that's what you're looking for, that should be your first stop. You guys can look these up when you have the time, because I know that we're running a little bit low. So I want to make sure that we finish up. That might be it, actually, right?
Yeah, all of this, and then the next one, this here is just additional resources that we used for this presentation, but both of these slides will be available on the resource list that will be sent out. I'll be sending it out today, and you all will have that available to you as soon as you get the email that says the recorded transcription of the webinar or whatever is available. This will be included with it. So you'll get all of this plus some additional little pieces like I mentioned. So it's 12:57. I think we have time to do one, Chelsea.
Go ahead.
I think we should do it, right? So
Okay.
It's all well and good that we talk about this stuff, but let's look at just one simple case study. I had 3, but we talked too much. So how can we apply this, right? We have Carlos, a 52-year-old man who frequently calls a crisis line while intoxicated. Let me tell you, if you have worked any sort of 24-hour crisis line, y'all know a Carlos. There's a Carlos everywhere. We've had more than one Carlos. It just happens. But he shares a mix of suicidal thoughts, past trauma, and frustration with the system. Staff feel overwhelmed and are unsure how to support him. Carlos is a veteran, has a history of childhood neglect, and has experienced homelessness for the past 5 years. He distrusts formal services and often hangs up mid-call. So thinking about what we've talked about, how might repeated trauma and systemic failures be affecting Carlos's behavior? You guys want to put your answers in the chat? That would be fantastic.
Connecting him with peer support, especially a fellow veteran.
Yep.
That's a great one. A fear of how he's going to be treated. Yeah, I bet that's a huge barrier for him. He might feel ashamed of mental health issues. Especially as a man, right? That's a huge stigma.
Yeah.
You should be tough enough to take it all.
Yeah. fear of stigma, lost hope. Yeah, I mean, ultimately, his behavior shows deep-rooted chronic trauma. It shows abandonment, and it shows ultimately a lot of repeat system failures and betrayals. He could be reaching out because that's the only way he knows how. And then he's able to speak for a couple minutes, but then retreat when the other person says something or he feels as though he's unsafe. A lot of prior experiences and stigmas and stuff, of course, it's natural that that's going to affect him. We as helpers or caseworkers, whatever we are, you know, if we shift our thinking and our judgment again from manipulative attention seeking to being more, okay, this is survival driven, right? This is what he knows. He's more likely doing the best he can with what he has, right? Just that shift, you know, from judgment to curiosity. You know, what does help look like through a trauma-informed lens in this case? What do we think might be the best help? Meeting him where he's at? Yeah, attachments. Could his use of alcohol stem from serving coupled with past trauma? Of course, right? I mean, you think about it, especially a lot of people who served. Look, back in the day, alcohol was not talked about in this way, right? I mean, smoking was great, drinking was great, everything was great because it hadn't been around long enough to see any detrimental side effects, right? So, of course, that plays into it. Definitely just listening, right? Yeah, mental health. Yep. Yeah, it might not look, you know, helping somebody doesn't have to mean, okay, we need to do this right now and get you into treatment and stop this substance abuse and, you know, have this really big timeline, right? Sometimes it just means shutting up and listening, right? Being present without judging him at all, validating how he feels, offering consistent but low barrier options, again, options for him to choose from, but ultimately respecting whatever he chooses. Whether you agree with it or not is not the issue here. It's up to him. Peer support, I saw that mentioned. And they even have like veteran specific peer supports now, which are huge when we get into, you know, someone's background, whether it be cultural views, religious views, race, whatever. If someone is more comfortable or can relate to somebody better, then look, I don't care if you talk to me. I just want you to talk to somebody, right? Like it doesn't matter to me where your help comes from. I just, these are your options. This is what we can do. You choose what's best for you, right? Because sometimes being helped means just being heard, just being listened to. Lastly, and the reason why I wanted to do this one is because it's so big here, but you know, we have Carlos keep calling. How can we avoid re-traumatizing, but also managing that overwhelming feeling and the staff burnout of, oh my God, Carlos is calling again.
Someone put in
Supervision.
supervision. Yes.
Yeah.
Yeah,
I love it. Like offer support for staff.
This is Mark. I was looking at that question, and it's one of those things that looking back at my history with I worked in probation and some other things. A lot of times, I think that idea of how we can avoid re-traumatizing while still managing that burnout. Sometimes, you know, I think Eric, you just said it a moment ago. You know, sometimes we'll really empathize with the person or say, "I know what you're going through," as a way to really relate. And I just wanted your perspective on that kind of conversation, because like I look at it as, is that me actually interjecting my views of alcoholism? And to say, I know what you're going through is, I know what I went through, or I know what my experience was. But if I say, I know what you're going through, how that might even shut down that person or even increase my burnout.
Yeah. I mean, personally, I don't like, I know what you're going through. Because again, like no two situations are the same, but the big thing in trauma, No two people are the same. So how I feel or how I take it, even if it may be similar, is not the same, right? Different backgrounds, different everything. A better way to do it is, number one, like Chelsea was saying earlier, normalize that those feelings you're having as a staff member, those are normal, right? Secondary trauma, vicarious trauma, these things can happen. They are real. It is proven. It is not just you or how you're handling this, right? And providing that time with that staff person to reflect or have that supervision. Also, setting emotional boundaries, huge, without becoming detached, right? How can we help this person without giving too much, but without coming across like just another person that scratches them off the list, right? But learning how to set those boundaries. You know, in our line of work, we spend so much time talking about boundaries, and yet it's so important that we as professionals set ours as well. Establishing team-based care. So you know what, Chelsea, I can't do this today, right? But Chelsea is familiar with this case, so Chelsea's going to take this today because I'm not in the space. I don't have the capacity to do it today. Definitely meeting Carlos where he is, but you know, using that trauma informed type of language that honors Carlos as a person and letting him make those decisions. But you know what? We're here if and when you're ready. And we want to help you. If we aren't giving you, you know, what is it that you need? If we are not giving that to you, let's see if I can find somebody who can, because I'm okay with admitting I don't know. I don't know how to help you, or I don't know what I can do, but that doesn't mean I don't want to try, or I don't want to be there. A lot of times, you know, we have this, like, we have to fix, right? That's what we're here for. We have to fix this problem. And that's so not what we're here for. That's what leads a lot to burnout and having those unrealistic type of expectations. Especially, gosh, so many cases can be so complex. It's hard. But thank you everybody, you know, for participating in our little case study here. I really just thought that it would be a great way, like, okay, we talked about this stuff. Now, how can we put it to use? One other thing I wanted to mention before we open it up for full question and answers, because I hit the wrong button earlier. Somebody had asked about, they were interested in becoming a support person or hotline crisis type worker for whether it be domestic violence or suicide or any of the above. And they wanted to know about finding resources. I accidentally clicked answer live instead of type. So they've just been waiting. But the best thing I can tell you is every single program or every single county has a program similar to ours. And on your resource list, I'll make sure that there's a special note on there of where you can look to search to find your specific counties. Contact them. We have a volunteer program. A lot of programs do. A lot of the crisis centers also have trauma or also have volunteer programs. You have to contact that specific program in order to get their volunteer information or application. Typically, they provide all the trainings and help you get there, but please reach out to them. I know us and millions more are always looking for help any way we can. So please.
Yeah. I will say, if you are somebody that's interested in volunteering with someone like VIP, I mean, we're very specific to our counties, but the thing I don't think many people realize is that when you volunteer to take just a shift on our crisis hotline, like maybe you say, I can do from 5 p.m. to 9 p.m. every Tuesday night. Our staff is on call 24/7. So we have staff members that are going into the office at 9 a.m., working with people in trauma all day long, and then answering that hotline the rest of the night until they go into work at 9 a.m. the next day. So just by you taking those few hours a week during like dinner time means that our staff gets to go home, have a dinner uninterrupted with their husband, their wife, their family, their children, whoever, and not worry about getting a phone call. And it might only be 2-3 hours a week, but oh my gosh, is that helpful. I cannot stress the importance of volunteering enough, because I truly think our crisis hotline is one of the biggest causes of burnout in domestic violence staff, because like I said, if it's not a volunteer, it's us again, all day, every day. So having that little bit of a break is really monumental. So if you are considering volunteering, like, this is your sign, please,
Do it.
please help.
And if you live in Wayne and Pike counties, Chelsea and I can be your backup.
Hit us
Because
up.
a volunteer always has staff backup, so you're never
Mhm.
on your own. We don't even expect you to leave your house ever. So, but another thing, I do a lot of trainings at the hospital and whatnot with healthcare providers. And another thing that I always tell them is, you're not usually meeting people on their best day. People working in probation, people working really anywhere in the court system, people are not excited to be there. Let's just be honest. They don't like us. So use the resources that you have available to you. When you're leaving work and you are constantly just thinking and stewing over that one person or that one case or that one patient, don't take that home with you, right? Hotlines like ours, it's not just for domestic violence, right? We deal in trauma. You call, right? It's free, it's confidential. We work with people every day for months or years on end, and I don't even know their real name because they've never given it to me, right? Like, we are so low barrier, and it's not just us. There are thousands of hotlines that are that same way. Use the resources that are available to you. And us as professionals, we don't do that enough. So it's super important for all of us to do that same thing. So if there are any other questions, now is the time. I don't know if you can come off mute and want to, by all means, please do that. Otherwise, you can share in the Q&A, or we're staring endlessly at the chat as well.
I also
yeah.
want to say a big thank you to Mark and Jamal, because none of these would be possible without you and all the work that you do. And we're going to miss you guys. We loved coming on here all the time. We love sharing knowledge, and you're just so easy to work with. And I think it's really important for people like you to bring awareness and education to such a large group of people. And it's awesome. So we're really going to miss you guys.
Thank you. And it's a great plug, as I just put in chat for anybody, to sign up for the Youth and Family Training Institute's email blast. They're going to be continuing some webinars, and hopefully with Jamal and some of the team, we'll be able to maybe bring VIP back for some special guest appearances.
That's what we're hoping for.
Mhm.
Me and Jamal, we go way back at this point.
Way back. We are thankful for the kind words. We are looking forward to, and hopefully, this year funding wasn't released, so there are a lot of grants and in other situations, people who are in the same position as we are, and we're hoping that next year, once things settle down a little bit, that we, those funding opportunities do get released, and we'll be able to come back in some way with our system of care grant and do these things. But in the meantime, we are hoping to continue doing some of these things with YFTI, providing some webinars, some knowledge, some resources for people who are looking for things. So we look forward to continuing to work, like Mark has said. remain steadfast in our vision, our goal, to help however we can. So, you know, we want to strive to continue and do this work because we think that it is worth it. So, I see a hand raised, and I want to know if it's by mistake or if someone has a question. If you would like to come off mute and you would like me to bring you into the conversation, just let me know and I can do that. All right, not seeing any takers. You get the certificate of attendance after you fill out the evaluation. You should receive a link, and that will take you to your certificate of attendance.
I'll put that right here in the chat.
Oh, I see somebody saying that they'd like to speak.
Paul,
Paul, yeah.
see if we
Stop
can
sharing my screen. I didn't realize I
bring
was still
Paul up here. Did you guys catch Paul's last name?
Was it conflict?
Oh my God, you're gonna make me go all the way
Hunter?
back.
Nope, I got it. Yo, Paul, if you come off pause, if you come off mute. Yep, there you go.
Okay. Okay, can you hear me?
Oh, Paul.
Yep.
Yes.
Okay. Um,
It's all broken up now.
Oh,
my
I'm
name
sorry.
is Paulette Hunter. Okay. Can you hear me now?
yes.
Okay. My name is Paula Hunter, and the reason I want to speak is because I called the 988 number because I was going through some stuff, and my mom also is going through some stuff because her daughter died, and I wanted to refer the line to her also, so I wanted to see what it was all about. And the first thing that came up on the line was suicide and crisis line. The word suicide was mentioned.
Mhm.
And ever since then, all I can remember is suicide. It seems like it planted a seed in my brain by saying that word. So I'm wondering if you all can help me or pass the word down to the federal level that maybe they want to change the word from suicide to mental health and crisis. Because the word suicide in the helpline, it kind of plants a seed in your brain and make you start thinking about suicide, which is not what you want to do. And so if they change it from suicide to maybe mental health and crisis, that could help a lot. Just
Right.
just a suggestion.
Yeah, I hear what you're saying. I think you're right. And we talked a lot about language today. So sometimes the language we use feels really scary and we don't realize the impact that it's going to have on somebody. So that definitely is a good thought. And I'm wondering if there are other like other warm lines or crisis lines that are more for mental health. And I know that they exist. I just don't know them off the top of my head, Paula. But there's also some at the county level too, or at least I hope there are. And it all depends on where you're located. But it might be a good idea to start with your local, like local government. Like I don't know if you have county commissioners, asking them, do we have any warm lines here? And if not, can you be part of getting those things set up so that people don't find themselves in your situation in the future? Where now this word is just like hanging over my head, but that's not what I initially thought about. I just needed somebody to hear me out. But I would definitely try to look into your local government, local mental health services if you have any, and see what lines are specific to your county too, because I think the 988 number is really just I don't want to say a quick fix, but it's the one that comes up most. And usually they are dealing with people who have suicidal thoughts. So
Yes.
that language works for them, but
Yes.
that just might not be the place that was right for you in the moment.
Yeah, it's also
Yeah,
interesting.
that-
I just went to the website for the 988 Lifeline, and they've actually changed the logo a little bit. So it does say 988 Lifeline instead of the 988 Suicide Crisis Lifeline. And still in the language, in the description, it does still say that suicide and crisis piece. So it's just, it's a well taken point, and I think there's various studies that also say by talking about suicide doesn't necessarily increase the probability. It's there if it's there, but it's also by mentioning it doesn't necessarily bring it as a higher rate. But I think it's a really good point that maybe even starting off with crisis and suicide versus suicide and crisis, maybe even as a way to tone it differently a little bit.
Yeah, and a lot of counties, I mean, I know that's one of the resources that I have listed as well. But a lot of counties have local mental health resource or hotline resources as well. Where in my mind, I always think so much better in a lot of ways to start local, because they are these are usually people that live and work within those communities. They are familiar with the other resources and stuff that are available, for right here, right now versus statewide. But yeah, I mean, obviously they say, especially when it comes to suicide, right? Like that's the word you want to use. You just want to come right out and say it. And it's hard to find that balance for sure.
I
yeah,
see a hand up
any
for
other
Leslie.
questions? I thought, is there, I think Erica's answering that one. Okay.
Yeah.
All right. Does anyone else have any other questions?
I see there's a hand up for Leslie.
I don't see a hand. Oh, I just raised my hand.
Leslie, if you want,
Oh, there it is.
bring you up to talk. It is up to you. You had a question? You can unmute. If not,
Let's see.
And this says the certificates do not seem to include our names. How do we adjust that?
yeah. So with that, it's an Adobe form, so you should be able to right where the name is. You should be able to either download it to your computer or do it right from the web browser and save that document with your name typed into it.
Let's see. Jerry, did you have a question? Does not seem to be.
There's a question that was here. Do you have any advice about talking to coworkers about the language they're using that might not be trauma informed? I've had coworkers and even supervisors who were extremely defensive, and it was hard to work around that. That's a tough one because people just naturally become super defensive. Like you're telling them they're doing something wrong, right? Obviously, if there is somebody above them that you can go to, not to get them in trouble in any way, you don't even have to mention that specific person, but just, hey, here are some resources that I found that maybe we can talk about during next staff meeting, so that it's a generalized, how do we change our language to having a more trauma-informed culture organizationally? That is often an excellent way to do it. Also, there are speakers that I know we always at our staff meetings, we always bring in outside speakers to talk to us about various topics. That is, again, another great option here within Wayne and Pike County. That's something that we could help with, there's a lot of different places. The issue is when it's your supervisor, that's really bad. And there's no quick or easy fix, except, you know, depending on what your relationship is with that supervisor. You know, with mine, I know that I can go and talk with her, and that defensiveness or anger type response I know isn't going to be there because it's coming out of a place of concern from me. But not everybody has that, you know. So in those cases, if you don't have that, I would say your only option is to then go to their supervisor. Because if the person at the top is not speaking correctly or in that trauma informed manner, you're not going to be able to fix it, because that's an organizational problem from the top down, and that's something that they have to change in their beliefs. I don't know if that makes any sense. I don't know if I picked the right words, but
No, I think it does. And if that's the case too, and it does, like when it's so high at the top like that, it feels like you can never do anything to change it, and like you feel defeated. But the best thing you can do is keep using trauma-informed language and just repeat it. And if you feel bold enough, correct them when they say it. So when you hear somebody, I'm just going to use examples. Like if you hear somebody in the break room talking about like their pain in the A client, correct them right there. We don't talk about clients that way. We don't use that language. Why did you think it's appropriate to use that? If you feel comfortable questioning them, question them. I'm all for making people feel uncomfortable when they are making me feel uncomfortable.
yeah. And power dynamics within the organization 100% reinforce the way clients are treated. You know, so much of it is the culture of the workplace. And that's why it's so important that that people are informed about like sexual harassment in the workplace or violence in the workplace, abuse in the workplace, because these are cultural issues. And they need to be addressed because they happen every day.
Mm-hmm.
I know a lot of people, I guess they're having trouble with like accessing or finding the link for the actual certificate. They're saying that they're not getting the link, or okay, then it's the most recent link that Mark shared took me directly to the certificate. It's going to say the whole link and certificate. That's not me and Chelsea. Be mad at Jamal and Mark for that. Nope, not me and Chelsea.
Yeah, please, if anyone has not received a certificate, and they are having trouble with receiving the certificate after they complete the evaluation, please email us at info@pacarepartnership.org, or you can email me directly at forj3@upmc.edu, and we will make sure that we get you a certificate.
Yeah, a couple more minutes. Is there any other questions anyone has for us?
Yep, and the evaluation will pop up at the end as well.
Jamal, that email that you just shared.
Yep, I'm going to put it in.
Thank you.
Yep.
Well, I want to just say thank you to everybody. I know a bunch have already had other meetings to get to, but thank you all so much for joining us again. I know there were some people that have said they've signed on to more of our webinars that we've done with PA Care Partnership in the past. So seriously, thank you from Chelsea and I both. We really appreciate it. We love coming on here and talking with everybody, and we learn just as much from the information and questions you all ask. And I hope that we give to you at the same time. But seriously, thank you. We appreciate it, and have a great afternoon.
Enjoy the last few
all.
days of summer.
Thank you all.
Can it, Chelsea?
Just to let you all know, we have our last webinar is coming up at the end of the month. I'll put the information for that in the chat for you to have. It is Youth Development and Healing with Thermel Brenson on Wednesday, August 27th, same times, noon to 1:30. And we look forward to seeing you there. And I will also, because I just realized that I was sending a direct message when I put the email information in there. And that's the email information for those of you who are experiencing issues with receiving a certificate or the evaluation. Please just email either one of those accounts and we will get back to you. Thank you, Chelsea. Thank you, Erica. As always, you're wonderful. I hope that we can book something and possibly do something going into next year. We appreciate everything that you've done as far as presentations and providing information and resources for people. It's always wonderful and informative. And to everyone who is still in the room, thank you for your attendance, and we hope to see you on August 27th. Have a great one, everyone.
Bye. Thanks, guys.
Thank you.
Bye.